Well, it's so great to see you.
Hi, Scott. Welcome to New York.
Most people know you've been on our advisory board for umpteen years.
Couldn't be. I'm too young.
Diabetes health benefits so much by your incredible talent and skill. So, what's going on with you these days?
Well, I've been focusing on inpatient diabetes management. I want to introduce you to my student nurse practitioner. Come here, Joy.
Come on over here.
Joy is very smart. She's going to be an MP soon. She's also going to be a mom soon. Can you get that?
Congratulations.
Thanks. So,
Great.
she and I go around the hospital and we see patients who have high blood sugar, and we're the hyperglycemia police.
That's right.
A little closer. You're the hypoglycemia police.
We are.
The hyperglycemia or the hyper?
Well, either one. Either one. We're there.
So if you see a high blood sugar, what do you do?
We give people insulin, because that's the best thing for high blood sugar that we know.
Which kind?
Well, we use rapid acting and we use long acting. And we actually have insulin pens in the hospital now because we want patients to be exposed to pens. It's a great opportunity for them to see them, sometimes for the first time, and if they want, they can learn how to use them and go home on them.
Do you do the disposable pen?
We do.
Okay. I just got the Novo pen.
You did?
It has cartridges. But it seems the insulin kind of squirts back out when I pull it out.
Scott, I did not train you. You need to be retrained.
Okay.
Re-educated.
Joy and I both knew it's very important to do an air shot first to make sure that the pen is working properly.
I've done that because I flew on the plane. Yeah.
You dial up 2 units and you express it in the air to make sure that insulin comes out.
Okay.
So now you know the pen is working properly and the needle has been attached properly. Then when you go to dial your dose and you actually inject, it's very important that you depress the plunger all the way down, and then depending on how many units, you count between 5 and 10 seconds. So the reason you're squirting is, you know you got that tiny little needle with that tiny little opening? It takes time for the insulin to be driven through that tiny opening. So whatever kind of insulin you're taking, whether it's in a vial and syringe or in a pen, it doesn't make a difference. After you depress the plunger, depending on how many units, you got to count to 5 if it's a small amount of insulin, let's say Novolog, 4 or 5 units. If it's a big dose of Lantus or Levemir, you may have to count to 10.
Okay, yeah. Those usually I just take like 2 units, sometimes 1 unit. Is it accurate at 1 unit?
Yeah, it is in a pen. It is.
Okay.
Even Joy knows that. She's a student. What's the matter with you, Scott? How many years have you had diabetes?
I've used just a syringe for so long. You know, I was a doubting Thomas, so I'm new.
Well, my belief is if I could only study this, you see what she says? The reason the pen is better, it's easier to see the numbers. So I think people are more accurate.
Right.
So you don't have to worry, is it the top of the black that I'm measuring or the bottom of the black? You have an audible click and you can feel as you rotate it. I taught a man that had very poor vision, and he had to take 40 units of 70/30 twice a day, and he would click his way to 10, use a magnifier to double check that he was at 10, then he would click his way to 20, double check with the magnifier, and so on. He got a perfect 40 units every time. Not that the pens are recommended with visual impairment, but if the person can prove to me that they can do it correctly, why not? So here was someone that was not going to be independent in giving himself insulin, and the pen opened up that world for him.
So your hospital is going to have 2. Your hospital's going to have 2 inpatient diabetes educators.
Oh, I wish I could keep Joy, but she's going to graduate.
She's the best.
You're the best.
You're the best.
So,
where will you go?
I don't know yet.
got any offers, anyone?
Well, I mean, I hear
My star students.
the job
The
market is
resume.
tough for diabetes educators because hospitals aren't hiring as many as they should.
It's difficult
I mean,
for me.
is 1 enough for your hospital?
No, I work in a large institution, so it's difficult for me to take care of all of those patients. It's not possible. So what we try to do is train the other healthcare providers in the institution to do better. So we're training the house staff, we're training the nurse practitioners, we're training the PAs, we're training the bedside nurses. So we're all on the same page that hyperglycemia matters. Even in a couple of days in a hospital, it does make a difference. Everyone knows what the targets are, less than 180 on the general floors, less than 110 in the critical care units, and they're learning how to make that happen.
Wow, so the whole staff needs to become diabetes education.
Everyone
driven.
needs to be on the same page. It's really important.
How do you feel about the, I feel like there's a crisis in diabetes education where there's not enough jobs, CDEs, the job market is shrinking. And that, like New York City, they closed all these centers a few years ago.
Well, I'm happy to say that the center at Beth Israel just reopened thanks to the generosity of an outside donor.
Really?
So they did reopen the program that I was laid off from. Ooh, so that's a very good thing.
Fantastic.
Yeah.
Somebody donated?
$5 million, I think. It was a lot. I could do a lot with that kind of money.
That's fantastic. Did they invite you back?
You know, I don't think they did, but I think they know how much I love my job, so it would be
Okay.
ludicrous.
Yeah.
I'm very happy doing inpatient right now, and that's outpatient.
Yeah.
Inpatient is a huge challenge, and I know that people with diabetes sometimes are concerned when they go into the hospital because in the past no one's paid attention to their blood sugar and told them, oh, don't worry about it, it's only for a few days. But I think hospitals are beginning to really step up to the plate.
What percentage of hospitals do you think have a nurse educator such as yourself?
I have no idea. We're actually in the process of planning to survey people throughout the country through AADE. I am the incoming chair of the specialty practice group
Oh, you
for
are?
inpatient. And actually one of our members has developed a survey to find out exactly what the role of the CDE in the inpatient setting is. So I'm going to be really excited to see what she comes up with.
Okay. Because I know 47 states mandate diabetes education, but some healthcare plans say, okay, it's 2 hours for your whole life. And I feel a person with diabetes should be trained until they get it.
Well, one of the things people can do is talk to their employer and let their employer know that whatever insurance policy they're getting for them, if they get it through their employer, is not providing them with the care they need.
Because I have this dream that if I could communicate to all the patients to request a visit with the diabetes educator, it would create this huge hiring frenzy. Because there's not enough there's not enough educators right now.
No.
And it's an epidemic. It seems like we need to be gearing up, right? We need to be having excess because every day more and more type 2s and type 1s get diagnosed.
Well, the thing is that the hospital setting is actually a very common place where someone is diagnosed. When someone becomes acutely ill, it's not uncommon for blood sugar to rise. So of all the people in the hospital that have high sugar, which is about 1/3 of all patients, probably 1/3 of them have new onset diabetes. But it's not new, they just didn't know they had it.
Why would 1/3 of patients in the hospital have high blood sugar? That there are that many that have diabetes?
Some of it is what we do to them. Use of certain drugs like steroids.
So a non-diabetic could have an elevated blood sugar?
Yes, stress hyperglycemia from surgery, acute illness, the stress, certain medications. That's about 1/3 of patients with high sugar. Another 1/3 of patients with high sugar are people that actually had known diabetes. So they walked in and they said, hey, I have diabetes. The other 1/3 actually had diabetes and didn't know it. And those are the ones that have the worst mortality risk.
Wow.
So it's really important to identify them as soon as possible and get them treated. Actually, in my hospital, we're being very proactive about that. We just made a policy statement that all patients who have high blood sugar will have their A1C checked so we can date the diabetes. So someone that comes in with no history of diabetes and suddenly their sugar is high, instead of blaming it on the steroids and thinking it just happened, by doing an A1C, we can see that, hey, that A1C is really high.
Months.
Oh, yeah. So that's a way to diagnose them.
Does every patient get a blood sugar test?
Yeah, pretty much. It's a common part of the admission panel.
Okay. That's how you catch them.
Yeah.
Well, congratulations for all you do. I'd be interested in that number, how many hospitals actually have someone such as yourself.
Well,
I mean,
you
no
know-
one has you except Beth Israel, but as
No,
an educator.
I'm actually New York Presbyterian.
Oh, you're Presbyterian.
But I used to be at Beth Israel.
Okay.
So you were close.
Do you think it's like 10% or 1% or of hospitals that have it?
I have no idea.
Okay.
I really have no idea. But I do speak about inpatient management around the country, and one of the challenges I hear from many of the participants is that they don't have a designated person for diabetes. So it might be someone in nursing education or nursing administration or someone in nursing leadership that has diabetes themselves that's
see.
doing that in addition to how many other hats that they're wearing.
But it seems like there ought to be a rule that they have to hire a professional, not just hand it off to some nurse that happens to be around.
Well, it's interesting you say that because there's going to be some changes, I think, in the future. The Joint Commission actually says there needs to be a designated person. They don't ever say who that person should be, but the logical person is a certified diabetes educator. That's the person that's going to be able to coordinate the care of the patients with diabetes. So there's going to be a movement for hospitals to seek certification as a diabetes specialty hospital. and that's going to be a component of it. They're not going to be able to meet those guidelines without a CDE helping them do that.
We need more diabetes educators. We need them in the schools, we need them in the hospitals, we need them for all the outpatient clinics.
The American Diabetes Association is working with the school nurses, and they have a huge movement right now to try to correct that
Well, I mean, there's one nurse for
deficiency.
5 schools in California, so
That's a
it's
problem.
not something they can do.
Because sometimes children are not allowed to eat in the classroom, and someone with diabetes might need to eat in the classroom.
Right.
It's demoralizing to make them leave the classroom. Some schools don't let them test in the classroom. They have to go to the nurse's office and so on. So there's a lot of problems, but I know there's a huge push to correct that.
Yeah. Well, Jane, it's just been so great to talk to you here
Nice
on
to
this
see you
Manhattan
again,
Street.
Scott. I hope you come to
And
New York more often.
I hope you have just a wonderful
you.
career in diabetes
Say your
education.
name. I'm Joy Guevara.
Joy Guevara. And
I'll
is this
be
your
graduating in May.
is this your first baby?
It is.
Oh,
Yay!
congratulations.
Thank you.